Thank you for joining tonight's OTEP clinical case webinar. The topic is transferring between Sublocade, Buvidal, and sublingual buprenorphine. Tonight we have Professor Adrian Dunlop with us here, who will be talking about this topic, and he's actually one of the authors on the LAIB guidance, so we're really lucky to have him here. I'd like to begin by acknowledging the traditional custodians of the land on which we meet and recognize their continuing connection to land, water, and culture. So these are some of the places where people are joining from tonight. We have a lot of people from out of state joining, as well as someone from every local health district other than the Far West. But I know we do have some people from the Far West who join sometimes. Regardless, thank you for joining tonight, as well as to people in all of these different specialties. We have a lot of nurse practitioners, more than usual, which is great to see, as well as lots of nurses, pharmacists, and medical practitioners. Just a little bit about the OTEP clinical case webinar series. These are monthly webinars that we hold on Tuesday nights with different topics each month. And after attending live, we will also email a certificate that you can use for CPD if you'd like to claim that. The webinars are also recorded and will be made available on the OTEP website for viewing later on if you'd like. And some quick housekeeping before I turn it over to Professor Dunlop. Please keep yourselves on mute unless you're asking a question, but we do recommend that you type your questions in the chat and we'll monitor the chat during the webinar. And if we have some time afterwards, feel free to unmute to ask any questions. And also, please just remember that these webinars are recorded, so please don't reveal any identifying information about yourself or others that you mention. And please be polite and enjoy the webinar. I'll turn it over to Professor Dunlop now to share his screen.
So thanks for the invitation to talk to you all tonight. It's a pleasure to be invited to speak about long-acting buprenorphine. We're in the unique situation in Australia of being the country with the most rapid uptake of long-acting buprenorphine treatment in the world. Finland has a higher proportion of patients, but fewer total number of patients. So we've certainly gone from not knowing a lot about it in less than a decade to it being a very commonly prescribed medication. So yeah, very happy to talk to you about tonight. The learning objectives we've got, to talk about the pharmacology of buprenorphine, the sublingual and long-acting formulations, including the weekly and monthly formulations, general approaches to switching patients between the different formulations, short to sublingual, short-acting to long-acting and vice versa, or between the different formulations of long-acting. And then time permitting, we'll talk a little bit about the approach to transferring patients from methadone to long-acting buprenorphine as well. So that's the general plan for the night. Like to acknowledge my co-authors, Nick Linzeris and Michelle Schultz, who did the background work in preparing the short version, the brief guide, and the long version of the long-acting buprenorphine New South Wales guidelines, updated nearly 2 years ago now. Doesn't time fly? And to our knowledge, these are still the only guidelines in the world that cover both formulations, because in countries that have long-acting buprenorphine, typically they've got Sublocade or they've got Buvidal, but they don't have both. So again, we're in a unique position then. And yeah, just to declare that the health service that I work for has received funding from Indivior in Canberra, so I haven't directly received funding. And also I have been on an advisory board, but as an honorary unpaid for Camrus regarding long-acting buprenorphine. So very quickly at the start, to go over some basic pharmacology. You've probably all heard this many times, but it's worth just briefly going over. So how do opiates work? Most of the effects that we think of as opiate effects, both positive effects like analgesia, but also side effects like respiratory depression act through the mu opiate receptor. And if you think of full agonists like methadone, heroin, morphine, etc., if you graph the dose against the effect, then you get an increasing effect until eventually that tapers off, and that tapers off because of respiratory depression. Naloxone, of course, you get no opiate effect, no positive opiate effect. In fact, you can get a negative effect or a withdrawal effect if somebody's opioid dependent. If they're not opioid dependent, it'll just reverse the effects of the full agonist. But the interesting thing about buprenorphine is that it's a partial mu opiate agonist. It has this ceiling effect different to the ceiling effect with full agonists. It's not because you get respiratory depression, it's that you just get no further effect. And practically that's something around the 16, maybe 24 for some patients, maybe even 32 milligram sublingual dose for some patients. That's where you get that ceiling effect. So the three factors: high mu receptor affinity, so it tends to displace other opiates if there's other opiates on board. Not as strong activity, but still well and truly strong enough to get decent opiate effects compared to full agonists, and slow rates of dissociation. So slightly different concept to half-life, but you can sort of think about it like half-life. So it tends to hang around in the CNS and produce its effects for a while. And then just as background, I want to walk you through this graph. You've seen it in the guidelines if you've had a look at the guidelines. And we created this to really have some graphical way of comparing the different long-acting formulations to sublingual buprenorphine. So there's a few key figures here. In the individual bars against each dose of each formulation, you notice there's a number in the middle, and that's the mean concentration of the drug. So you can see that's the one for sublingual: 1.37, 1.79, 2.16, 2.84, 3.68, etc. So that's the mean concentration on the interdosing period. And then at the bottom, you've got the trough level, and the top, you've got the maximum level or the peak level. And you can see now how that compares between the different weekly and monthly formulations of Buvidal and the two Sublocade formulations compared to sublingual dosing. Essentially, there's a range of doses from lowish to highish. The highish peak doses are seen with 32 milligrams Subutex and 160 milligrams of Buvidal. The highish area under the curve, or dose, average dose, rather between doses, is with the Sublocade 300 milligram, and you can see the various trough doses there as well. So I'll come back to this, but that's an important concept to be aware of in trying to compare doses and thinking about switching doses and how we go about switching doses. The other concept that's also important to think about is the duration of action and when you get peak effects. And if you look at the graph here, you'll see in the light grey, there's the graph, two things you notice. First, there's the graph for the average dose. That's the middle line, the dotted line, for sublingual buprenorphine. So you get effects pretty quickly. Within a couple of hours, you're getting peak effects, and then the dose is starting to taper off over the next 24 hours. So that's the sort of dose response we get from a sublingual dose of 16 milligrams of buprenorphine. In comparison, a subcutaneous or depot dose of buprenorphine, 16 milligrams of Buvidal, you can see much slower onset, and then it flattens out at around 10, 12 hours. I'll show you what happens after 24 hours in a moment. But that's really important to consider. Why is it important? Well, for a start, it's rare, really rare these days to see precipitated withdrawal from somebody starting from street opiates. As long as it's not a long-acting opiate, we see it very, 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 very infrequently. In fact, I'm struggling to remember the last time I've seen that. So the anxiety that we had about starting sublingual buprenorphine, generally you don't have to worry about with long-acting buprenorphine. If the patients come in and use that morning, you can still start long-acting buprenorphine the same day, and you're not going to run into this problem of precipitated opiate withdrawal. So that's useful. Also important in how we think about using prescribing buprenorphine, because there's times that in the past we think about, let's give a test dose of buprenorphine. That's where you're risking giving precipitated withdrawal. I know there's reasons to give a test dose, but in the main, we don't need to do test doses, and that's a good thing. So the curve of buprenorphine, the sublingual doses, onset pretty rapid, peaking within a couple of hours, offsetting by about 4 hours, and then diminishing over the next day. If we then think about comparing that to the long-acting buprenorphine on the left, you'll see there's a simulated dose of the 16 milligram sublingual buprenorphine. You can see absorption peak and then trough over the next 24 hours, one day, et cetera, going across a week. Comparing the weekly formulation of Buvidal, in this example, it's a 24 milligram dose. You can see you're getting that peak around half a day or so, 10, 12 hours, and then slowly diminishing. With the monthly formulation, the peak happens quicker, happens in like 6 to 8 hours, something like that, and then it slowly diminishes. So that's important. The other important concept to remember, we'll come back to it. You can see it with error bars on this graph, but that is to remember that there's interpatient variation. So you can think of it like a normally distributed curve. You get most people having the average effect, 2/3, within 2 standard deviations, but you still will get people outside that. And so there's times when a sublingual or a long-acting dose might do more than you thought or less than you thought. And we'll maybe talk about that a bit more in the examples. You can see it on the graph on the right here, where there's shading around the 95% confidence interval for the doses. So just to reflect, that's what's happening. How much buprenorphine do you need to prevent opiate withdrawal in dependent people? Not that much. So probably half a nanogram per mil. Not that we can ever measure nanograms per mil in patients, but probably something like that. Not very much. And the end of the didactic part, the pharmacology review. So Sublocade, monthly formulation, not a weekly formulation. And to compare it to monthly Buvidal, 2 things. The area under the curve, or the average dose, is higher, and the trough is higher. I haven't got a slide where you can compare directly side to side, but if you think back to that graph back here, if you look at Sublocade and then look at the monthly doses, so higher average doses, 6.32 compared to 5.27, and higher trough doses, 5.47, say, compared to 2.66 of Buvidal monthly. And yeah, the approach generally for patients is 2 300 milligram doses and then swap to the 100 dose. That's enough. You've got steady state after the second month. With the 300 ongoing regimen, you don't get steady state until about 6 months. down the track. So you're going to get more effective and more effective and more effective each month. If a patient wanted to swap from sublingual to long-acting buprenorphine, what are some of the key things that you'd want to know? And maybe if people could enter in the chat.
Can you
What's the question again, please? If you're going to swap a patient, let's imagine a patient comes in to see you, says, I'm on my Suboxone, I want to go on to the injections. Some of the key questions, important questions to ask. Yep, when did that last dose? What dose? Yep. Other drug, of course. Long-acting opioids? Yep. Current dose? What else are you using? Yep. Have they ever tried illicit bute before? Let's say it doesn't matter. They're on prescribed bute. Is it holding them? Yes, very good question. Is the dose adequate? Are they still using? Yep. So illicit opiates. How's your liver? I hope my liver's okay. How's the patient's liver? I hope that's okay too. But yeah, it's something to consider, particularly because one of the reasons to be cautious with long-acting buprenorphine is people who are in liver failure. We'll talk some more about that. Why do they want to do it? Are they pregnant? Yes, and if we go down that path, we can actually talk a little bit more about pregnancy. Let's go off on that tangent. That's good. Great. Okay, how about let's pop up some of the options and we can get people to vote. So I just narrowed it down to a few groups. So let's say it's a patient, male, 35 years old, on sublingual buprenorphine, 16 milligrams a day. He's been on this for a while. Let's say he's getting a couple of takeaways a week because we're pretty stingy about takeaways from Suboxone in Australia. Wants to transfer to long-acting. Likes the idea of convenience of dosing, lives about an hour from the pharmacy, so it's a pain in getting there and back. What other questions do you want to ask? So you can vote A, B, C, or D. And everybody's voting D. Fantastic. Okay, so they're the key things you want to know. Is it working? What do they understand? Are they well educated? Patients are generally pretty well educated about long-acting buprenorphine. They know that it stings a bit, can be a bit unpleasant. For some people, that puts them off. They know you can get a bit of a lump from it. It's generally not too bad, but they know it happens. But people generally know, yeah, it's a lot different being on a weekly or monthly medication than having to take it every day. And for a lot of patients, they like that. Not all, but for a lot of patients, they like that. What's the other drug use? Use of heroin, other opioids, other sedatives, other stimulants, and are there any contraindications? So liver failure is one. Okay, so next question. What dose are you going to give them? If it was Buvidal, what dose would people give? I'm going to type it in the chat. 96, yeah. Any other guesses? 64, 96? 64, 24. Some weekly doses? Yep, I didn't actually say. So weekly or 20, or weekly or monthly. Check the advice and the guidelines. Yep. Use a conversion chart. Yes. 24 weekly, 96 in review. Monthly, 96. So it looks like people are generally going around, if it's the weekly, the 24 milligram dose. And if it's monthly, the 96 milligram dose. And I'm sure everyone's worked out that 24 times 4 is 96. So it's pretty easy to convert between the weekly and the monthly doses. How about if the patient, you spoke about the patient with Sublocade. What would people pick then? 300? 300, 300, 300. Looks like we're getting lots of 300s. Anybody going to go for 100? Going once? Going twice? Nobody's going for 100. Okay. I guess another question we could ask before we jump to the dose is, how would you help somebody choose? What would you say to them? What are some of the key things in a discussion with a patient about who wants to swap from weekly to monthly. Convenience, yep, but how would you help them choose between Buvidal and Sublocade? They're both convenient. Does this 100 milligram cause a lump as much as a 300? No, the answer is no. So the 100 is a 0.5 mil injection with the 19 gauge needle. It's a big size needle. The 300 is 1.5 mil. So that's one of the issues for some patients. That 300 milligram dose can be unpleasant. They might like the feeling of the big lump. Having said that, typically you can give the 300s and drop the patient down to 100. But so that's one thing to think about. And with Buvidal, the weekly and the monthly, it's from about 0.3 of a mil to a little over 0.6 of a mil. So more like the 100 milligram Sublocade dose. Kathy said she finds Sublocade better for chronic pain. Okay, great. Are there any advantages of using Buvidal weekly rather than monthly? That's a good question. I think how we've got used to using it is patients who are not familiar with long-acting buprenorphine, patients who we still want to see a bit, patients that aren't confident that the dose is really going to last for a month. They're the sorts of patients you might think about. Why don't you try the weekly for a while before trying monthly? I know in the start, when we started prescribing long-acting buprenorphine, the clinicians were a little bit anxious too about, is this really going to last? And so we found it easier starting patients on weekly if we're using Buvidal. But over time, most patients like monthly. Okay. I recall I was starting, did anyone ever cut out the lump? I'm going to come back to that. I hope at the end of the presentation I've got a slide. I think I'll remember that. Some for more closer follow-up to weekly hours more rapid titration. Yeah. So you can get, so given that it takes with most medications 4 doses approximately to get steady state, in 4 weeks you can have somebody in steady state on Buvidal weekly. It's going to take 4 months with Buvidal monthly. Having said that, the person's probably going to be stable enough not to be able to say to them, yes, you can safely drive a motor vehicle. If you see them in a trough and or in a peak period, you've got a sense of the effects of the drug. So that's the case. But yeah, you can get somebody to a steady state more rapidly with weekly. And Jackie said in Illawarra, it seems only Buvidal is being offered in the clinic. Thus comes to the community. In New South Wales, so there's certainly a lot more Buvidal prescribing than Sublocade. It's like a 10 to 1 or something like that. Who's it going to administer it for you? Yep. Okay, let's go back to talking about, I just noticed John said similar difficulties. Hornsby community pharmacies are actively disinterested. That's disappointing. I know we've been incredibly lucky and I've got lots of pharmacies in our district who are doing it. Let's hope that turns around. Can never get everybody, but it's good if we can get some more pharmacists to it. And Sandy's asked, is there a limit to the number of weekly doses we can give? That's a really good question. I'm going to touch on that in a second. So let's keep going. So what dose of Buvidal and what dose of Sublocade? Let's go back to that question. We've answered that all of the above here. So yeah, here's the table folks were talking about before. So this is the general guide to swapping between weekly and monthly, and sublingual and weekly or monthly. So you'll note 2 things. The first, there's not really a monthly equivalent to 2 to 6 milligrams sublingual or 8 milligrams weekly. So it means if you've got somebody, in fact, I've got a patient like this right now in a rural area, happy on 8 milligrams of weekly, wants to go to monthly. I'm going to have to meet with him tomorrow and say, we're going to have to think about this. Let's give you a 16 milligram or maybe a few 16 milligrams first, because you're going to find that it's stronger than what you're used to, and we don't want to oversedate you. So most of the doses pretty easy to swap for. 16 weekly is 64 monthly, 24 weekly is 96 monthly, 32 weekly is 128 monthly. But then there's a lower dose, the 8 milligram weekly, and a higher dose, the 160 mgs. And the 160 mgs is above 24 milligrams sublingually. The weekly dose is sort of at less than 8 milligrams weekly. Now, this is where you start. It's not set in stone. It's not a rule book. This is guidance, and you've always got to remember individual variation, patient to patient. Think again about that normal distribution or the 95% confidence interval graph I showed before. You will get patients who will get a lot more effects or a lot less effects than other patients, and that happens with all opiate treatment, and that's why you have to individually titrate doses and think about those issues of how long does it take to get steady state, when do you get peak effects, when do you get trough effects, when am I seeing the patient, is it at a time of peak dose or trough dose? If you're worried about intoxication, you want to see patients at their peak. If you want to see withdrawal, you want to see patients before the next dose when it's at the trough. So that helps you guide what you're going to do clinically. So that's sublingual. Couple other things to note. Yeah, we've talked about half-lives, no equivalence, and individual titration. The question just that Sandy asked before, is there a limit to the number of weekly doses we can give? So you'll notice 32 milligrams is the highest weekly dose. You can give up to 40 milligrams in a weekly dose. And how would you do that? You might give a patient 32 milligrams on day 1, and they come back and see you on day 5, and it's not enough, and you give them another 8 milligrams supplemental dose. Or more commonly, because 16 is the main starting dose, or 24, you might give somebody a 16 or a 24 and then come back. So there's not a limit so much in the number of doses, but the total dose. So 40 in a week, 160 in a month. It's rare to have to give lots of doses, but it's important to be able to give some patients supplemental doses. And often more anxious patients or patients that there's some reason I think they might be very tolerant, I'd write up their normal weekly dose, but then I'd write up some supplemental doses as well. And let's say, I'll give you a better example. The patient on 16 milligrams, you gave them an 8 milligrams. The next week, you're going to give them a 24 milligram, not another 16. And see if that's enough. And if they needed another 8 supplemental, then the next week, you'd be giving them 32 weeks as their weekly dose. Okay, so that's Buvidal. Transferring from sublingual buprenorphine to Sublocade. So generally, you commence with 300 milligrams, and you can give it the day after the last dose. You can even give it the same day if you need to. And then I was saying before, generally, you give 300 milligrams and then decrease to 100 milligrams. And so the question for everybody is, why would you continue on the 300 milligram doses after the first 2 doses versus go to 100 milligram? And there are some options there. So yeah, as you can see, A and B are really the answers I was looking for. Patient has regular non-prescribed opiate use, and or they've got significant craving or withdrawal, especially at the end of the month. That would be the reason to continue on the 300 milligram dose. And yeah, look, we always get patients who want to be on the highest dose. I try not to do that just as a reason on its own. There might be other things that make you think about it, but really A and B is what I was looking for. And then just to jump back, I can see Patrick said some of the LHGs have business rules on exactly how much to give in these circumstances. How flexible are these? And clinical discretion. I guess if you're employed by an LHD, the LHD might expect that you follow business rules, but then business rules never cover 100% of clinical situations. So if you are employed by an LHD, good to speak to your clinical director and ask them that question directly. There are always situations where we can't absolutely follow guidelines, but having a good reason to do something else is important. Okay, let's keep going. So yeah, A and B is what I was looking for. So here's the, this is again from the guidelines, just showing the approach. So give the 300 milligram doses. You can give it 2 days early or up to day 42. So up to a bit late. And then generally you want to decrease to 100 milligrams unless there's a reason, and you can see there adverse events is another example. Patient doesn't feel the dose is adequate. Okay, let's keep going. We've talked a little bit about this, the supplemental dose. So yeah, it's really there for situations where whatever dose you're giving isn't adequate and you need to give a little bit more. In practice, there was a multi-site trial. I've seen some of the data from it. It happens. It doesn't happen for the majority of patients and tends to happen early. And then the more doses you give, the less frequently it needs to happen. So it can happen a bit with starting somebody on weekly. It can happen a bit with starting somebody on monthly. You can give these in addition to the weekly or the monthly dose. You can give them in addition to either. And again, clinical titration to affect, noting that you generally don't want to have more than 40 milligrams in a week or 160 a month. Other limits. Now, we've also got a question. I'll come back to that, Kathy. So supplemental Sublocade doses. So our guidelines state if you've given somebody a dose of Sublocade and you think that's not going to be adequate, you can give supplemental sublingual doses. The guidelines don't recommend giving Buvidal supplemental on top of Sublocade. It's not a crazy idea. It's just nobody's collected any data or done it yet to know what it's like. So that's why we haven't recommended it yet. But yeah, if Sublocade is inadequate, then we recommend giving sublingual and starting at 2 milligrams and then increasing as needed. But remember, with Sublocade, you're getting those very, very high, much higher, especially the 300 milligram dose, average levels and trough levels. So you shouldn't need to do it that often. And I'll come back to that question about additional doses towards the end. Okay, so you probably don't have that sheet in front of you, but anyway, let's see how we go. Patients on 128 milligrams of Buvidal wants to transfer to a sublingual dose. What do? So they're on 128. What sublingual dose are you going to give? 24, yeah. Any other guesses? 18 to 24? 24? 18 to 24? Ooh, that's an interesting question. About those, can come back to that later. 24 to start with. So the general approach is that you wait a month at least. So wait 28 days after the previous dose, and then start at the bottom of that range and titrate up. So I'd start somebody on 18 milligrams rather than 24, see how they were, recognizing that the extinction curve depends a bit on how long somebody's been on long-acting buprenorphine, but it's slow and gradual. We know from that case example that was reported in South Australia that even with a single long-acting monthly dose, you can get some blood levels months and months afterwards. But yeah, so start at, say, 28 days and then restart on 18 milligrams and see if you need more. So that's for 128. I'll come back and answer some of the other questions, but let's go through some of these first. So the next one we're going to get you to look at was, oh, there it is, 64 milligrams. What sublingual dose? Yep, so we'd start at 8 and titrate up to 10 if needed. Again, remember that some patients will need more. Okay, probably don't have to go through all of these examples because I think it's reasonably self-explanatory. You look at the table. There we go. Went too far. Quick. Look at the equivalent and then transfer to the sublingual dose. So there's the same table the other way around. There's your weekly dose and your monthly dose, and there's your daily sublingual dose. Now, somebody had the question here. So you wait 28 days. That's right, yeah. The only situation I wouldn't wait 28 days would be if the patient was saying the dose isn't lasting for 4 weeks for me and I think I need more, then I might introduce it earlier. But if weekly or monthly dose is not lasting so well, might be a difficult transfer back to sublingual. Have to see. Okay, we'll keep going. So now transferring sublingual to Sublocade. Generally, the approach is to start on low doses and at the time of next long-acting due, titrate up as needed. So as a guide, 300 milligrams of Sublocade, you might require 24 to 32 milligrams of Suboxone. And Sublocade 100 milligrams may require 8 to 24 milligrams. And sorry, the titles are wrong around. This is about transferring for Sublocade back to sublingual. Okay, so now transfers between Buvidal and Sublocade. If you had somebody on 24 milligrams weekly of Buvidal, what dose of Sublocade would you transfer to? Everyone's going for the 300? Okay. What about 32? The answer's the same. Yep, 300s, 300s. A patient on 100 milligrams of Sublocade wants to transfer to Buvidal. What dose? 128s? Yep. So again, here's our guidance here. But if you're not sure, worth flicking back to the graph that we had right at the start and look at those average doses and peak and trough doses. In particular, look at the average, but also think about the peaks and the troughs to pick your dose. And a patient on 300 milligrams of Sublocade wants to transfer to Buvidal monthly. What dose there? 160? Yep. Yep, that's good. Now, I can see there was another question back here. Do you ever give a weekly injection and supplement with 8 milligrams sublingual film? So if the person's on Buvidal, if I was going to give a supplement, it would be more Buvidal, the 8 milligram Buvidal weekly. If somebody's on Sublocade, then yes, you could, if you thought you needed to, give some 8 milligrams sublingual film to reduce withdrawal symptoms for somebody who's using heroin. I mean, the key issue if it's occasional use, If it's regular use, then you probably need to be increasing the dose, or maybe the person hasn't got to steady state yet. So they're really the key principles here. Okay. How are we for time? 1:45. And there's a chart on transferring between the two. So Sublocade 300, the highest dose of the weekly, or the 128 or 160 monthly. The 100 milligram monthly can swap between the 16 and 24 weekly, for the 64 and 96 doses. Again, just to emphasize the point, remember there's individual variation. So there are times when you need less, there's a time you need more, but this is what you need to do on average. And then how long do you wait since the injection to transfer from weekly to monthly? The next week. So if somebody's on a weekly dose, wait 5 to 9 days afterwards, in a week on average, but you can give it a little bit early if you need to, and swap over. Okay, there's a few more slides to go through. Well, actually, first, because methadone transfers isn't the central part, but I'll just ask if there's any more questions first on transferring between different sublingual formulations of buprenorphine and the long-acting weekly or monthly. Not yet. Okay, so the last bit, I'm just going to briefly mention swapping from methadone to long-acting buprenorphine. So this is where it gets a bit tricky. And again, overall, if you look at any of the case series, the best outcomes are this works for about 4 and 5 people, 3 and 4, 4 and 5 people. And there's a group of patients that this just doesn't work for. Maybe people have been on methadone for much longer periods of time, haven't been on buprenorphine, don't like the opiate effect on buprenorphine compared to methadone, and you don't know until you've done the swap, but you don't get 100% success. So practically, the reason you get precipitated withdrawal is people don't get the same opiate effect with buprenorphine as they do with methadone, and because buprenorphine tends to displace methadone from new opiate receptors, that difference, even though they're still getting an opioid, is experienced as withdrawal. Now, practically, a really difficult thing can be to tell what's precipitated opiate withdrawal with what's just not giving enough opiates. So if somebody's been on methadone, you stop the methadone, they're going to start to get some withdrawal. Depends on the patient, 24, 48 hours, sometimes 72 hours. Some patients experience it more earlier, some takes it a bit longer. And this can be really confusing, and people can jump to saying, it's precipitated withdrawal. I think it's precipitated withdrawal, when it's not precipitated withdrawal. It's not getting enough opiates. The time course, you'll see, is very important. Symptoms tend to have a quicker onset and be a bit more severe with precipitated opiate withdrawal. And when is it going to happen? Well, if you think of sublingual, that first graph can be like 30 minutes, even a bit less. You can start to get it. Long-acting, it'll be a bit longer. It'll be hours rather than minutes after the administration of the buprenorphine. So there's some of the key factors in thinking about how do you respond? Because if it's precipitated opiate withdrawal, there's a few ways to respond. If it's that they're running out of buprenorphine, or sorry, they're running out of methadone, it's that they need some more opiates. We'll come back to it. Now, the first two options you can do in primary care. The second two options are due under the supervision of a specialist. So those two I'm just going to mention and skip over. So the first one, lower doses of methadone, so 30 milligrams less of a problem. So essentially not too hard to do. You can transfer using sublingual buprenorphine, and then once you've had the patient on some sublingual for a period of time, swap them over to long-acting. So that's not too difficult. The second one is you can go from low doses of methadone, so 30 milligrams of less, to long-acting buprenorphine. And how do you do it? It's still important to wait. So it might be more than 24 hours. Could be 2 days, could even be 3 days before that patient, even on a lowest dose of methadone, starts to get withdrawal. And then once you're satisfied you're getting some withdrawal, doesn't have to be a high COW score, but say 6 or more, give some long-acting buprenorphine. And then just for completeness, I'll mention the other two approaches. So in specialist settings, we can swap the patient over to another regular opioid, like long-acting, short or long-acting oxycodone or morphine. Do that for several doses until the patients can have far less methadone in their system, and then put them on Buvidal. So that's one. And the second one, you've probably heard talked about or read about, the microdose or the Bernese approach, where you have both methadone and buprenorphine going at the same time. And essentially you leave the methadone dose going and then slowly introduce smallish doses of buprenorphine sublingually and then ramp it up. If you do get precipitated withdrawal, in this case, it tends to be around that sort of day 5-ish, day 4, day 5-ish, once you're giving decent doses of sublingual buprenorphine. But I'm not going to spend too much time talking about that because we're nearly out of time and there's another couple of questions. So one is from Jackie. I'm a GP prescriber and haven't done a methadone to LAIB transition and I'm wary. Fair enough. I have a handful of patients who are very keen. Not sure if this is really in a capacity. So, Jackie, I would just suggest contact your closest public clinic and liaise with them, and they could possibly even take over the patient as an inpatient or an outpatient and do the swap for you. So that's what I'd suggest there. And Patrick said we had an RACGP addiction SIG on the newest approach to changing from methadone to buprenorphine. And there were 3 messages presented. Microdose, hang on, I can't see this bit here. Microdose, low dose methadone, and patches. Oh, yeah. So yes, I've still seen some of our Victorian colleagues present on that. I think they did it at the last IMIA. We haven't put it in our New South Wales guidelines. It's possible, but yeah, I haven't done it. Can't really comment on it. There's more approaches being studied at the moment, so I don't think we have the answer yet. I think for primary care, it's really that option 1 or 2. Can you get the patient down to 30 milligrams or less? If that seems feasible, you can try doing it yourself. If not, refer to your local clinic and ask them to do it, and they should do it. And Jackie says we can't. Yes, so specialists can get authority for both from PSV, Pharmaceutical Services, for a period of time. And the clinics are busy. Yes, they are. The number of patients has grown enormously. Our custodial system has become very efficient at putting patients on treatment who need treatment. So that's fantastic. And we don't have the data yet to really show this, but maybe retention in treatment with long-acting buprenorphine is better than sublingual. Certainly in some situations it is. So the total number of patients in treatment is growing and growing, and that's why the clinics are so busy. I'm going to stop talking there because Jessica's got 3 questions. But yeah, I'll also just leave a chance for final questions.
I've just sent a link to the feedback survey for those who want to leave a little feedback for this webinar. But you do have some questions in the chat.
Okay, yeah. Sorry, and so there was a question. I think it was Joyce said earlier. Kirby's mentioned too. So in the last couple of months, I think it's in JAMA Internal Medicine, the largest scale pregnancy study of weekly Buvidal. It's not monthly, just the weekly formulation compared to sublingual buprenorphine is published, and great results. It's not any worse. It was an inferiority study, so it's not inferior. And in fact, there were fewer positive urine drug tests for illicit opiates in the group randomized to buprenorphine. Importantly, the neonatal outcomes were no worse. They weren't any better, but they were no worse. So incidence of neonatal withdrawal requiring treatment, etc., were equivalent. So that strengthens our understanding on buprenorphine in pregnancy. Can you comment on switching pre-pregnancy? Generally, the approach, I mean, we could do another one of these on pregnancy, Jessica, and maybe at some stage we should. But generally, the approach on pregnancy, if whatever's working is working, if sublingual is working, then I'd leave the patients on sublingual. If they're on long-acting and it's working, I'd leave them on long-acting. There are data on sublingual Suboxone in pregnancy, and the naloxone does not appear to be a problem. And the last one, can you convert them to a buprenorphine patch? The problem with patches is the dose is so much lower than sublingual buprenorphine. So might be a little bit like the Homer Simpson episode with nicotine patches when he had patches all over him. I don't think that would be feasible. Oh, you're talking about can you do patch induction to swap somebody from methadone to long-acting buprenorphine? Yeah, that was that approach that some of our Victorian colleagues, Paul McCartney, has presented on. I don't know if they've published yet on it, so can't comment anymore, but they've certainly done that. So, yeah, the last one, you'll notice earlier this year, I think in January, there was updated product information for Sublocade put out by Indivior. And that's where they suggest you can give as frequently as 1 week apart two Sublocade doses. So they suggest it's in situations where you've got heavy IV use. And remember, in North America, where this experience is, there's lots of fentanyl, nitazines, other high-potent synthetic opioids, and they need to be able to manage that. And that's the background to doing these 2 quick induction doses. So important for us to know it's now in the Australian product information. You can do it. I imagine we're not seeing that much of this. There's been handfuls of cases in Western Sydney, but not many. So important to point out, in a transfer situation, I think this is going to be pretty uncommon, in fact, probably rare. The other thing that there was a question before, in the product information, it does also suggest you can surgically excise a Sublocade depot if you need to. I wouldn't suggest anybody does it. There's usually other ways around us managing patients who are on long-acting buprenorphine that we don't really want the buprenorphine there, but it's there. But yeah, important to note it is there in the product information.